So today we're doing a breast augmentation in a patient. So now she has given birth to a child 10 years back. She has lost a lot of on the breast after that. And she has a little bit of sagginess also. So this is grade 1 ptosis. So when we are doing the marking for such a patient, the first thing we need to do is mark the mid-axial line so that we know where the center of the body is, and accordingly we can place the implants on either side. After that, we mark the mid-axial line of the breast. Now, this is important because we want the breast implant to be centered on the chest wall. We don't want it to be on the right or left of the nipple so that asymmetry can occur. But if we mark the mid-axial line, then we know exactly where to place our incision and also the breast implant accurately. So accordingly, once we have an idea about the mid-axial line, we are going to place the incision also centered on that so that it remains absolutely concealed. If the incision goes too medial or too lateral, then the incision can become visible. So another thing when we are doing the breast augmentation to mark is the anterior axillary line which is on the side. Now, why is this important? Because the implant, we don't want it to go too lateral. Otherwise, the implant is going to end up in under the armpit. So we want our dissection to be limited over here so that the implant remains on the chest wall and doesn't go too medial or too lateral. So similarly, we mark the medial line as well. So these landmarks guide us where to place the implant, where to place the incision, and to get accuracy on both sides. So how do we decide the placement of the incision? So we do is we measure the distance between the nipple and the IMF at maximum stretch. Now let's say the arc of the implant, that is the lower arc of the implant, is more than this distance, then we lower down the incision. So for example, the arc is 12 centimeter and this distance is 10. So the incision will be 2 centimeter lower than the IMF. Here the arc is actually less than the distance between the IMF and the nipple. So we are going to place the incision within the IMF. There is no need to lower it down. Another important thing, if we are lowering down the IMF by more than 2 centimeters, then we need to recreate the IMF by taking sutures with the thoracic fascia. But that is how we decide the location of the incision, whether it has to be within the IMF, lower than the IMF, and how much lower than the IMF. So here I am infiltrating in the subcutaneous plane. I'll go a little bit deep because I need to cut the muscle over here. So just go touch the costal margin, give some infiltration there also to ease my dissection. Very important to aspirate before you inject over here. I'm going to inject a little bit here, medially and laterally in the subcutaneous plane also because I need to do a dual plane. So this just makes the dissection a little bit cleaner rather than having bleeding all around in the subglandular plane. So while dissecting, you just bevel it cranially because we want this extra fascia to be here so that when we are recreating the IMF, we have some tissue. So just angle your dissection slightly cranially to about 15 to 20 degrees. All the while to maintain hemostasis. So once we see the muscle, we have to be sure whether it is the rectus or the pectoralis. So one way to do is use coagulation and touch the muscle. See, the contraction is occurring in the axilla. That means this is the pectoralis major. Where the most of the contraction is occurring in the thorax. That means that's the rectus abdominis upper fibers. So if you enter the deep to the rectus abdominis, then you'll have a lot of bleeding also. So once we do that, now we're going to continue in the subglandular plane till the nipple to do our dual plane. So now my lateral dissection is only till the anterior axillary line. I will not go beyond this because if I go beyond this, the implant will just fall into the infra axillary area. So we need to limit the dissection to this anterior axillary line. So this is the funnel that we are going to use to place the implant inside. Just open the funnel. There's a piece of paper inside. We remove this. Wet it with saline without touching the inside of the implant. Once you have inside saline, just hold it and shake it to hydrate the funnel so that the chemical inside is activated. That's it. Now you're going to push the implant into the funnel. तो खोलना नहीं है, अब वो ले लो, ये ले लो. So now even we before the open the pack, what we are going to do is we are going to inject some betadine inside. Why? Because of the processing and packaging of the implant, it has some static charge to it. If I just open it, the dust in the air can get stuck to it. So we're just going to remove the static discharge by washing it with betadine. This. So we've broken the tip of the needle so that it doesn't injure the implant. I'm going to look where the implant is, away from the implant. I'm going to inject this blunted needle inside and push the betadine in. This was 10 ml. Going to use another 10 ml. Oh, wash the implant nicely with the betadine. The implant is already bathed in betadine even if before we have removed it. Now my assistant is going to open it and push it into the funnel as I hold it open. So we have the implant in the funnel and we haven't even touched the implant. So now my assistant, we're going to cut this. According to this, so this is around 550 cc. There are markings on the implant on the funnel. So accordingly, I've made a 5 centimeter incision. So I'm going to cut it around 5 centimeters. That's it. The implant has been inserted outside. Forceps inside. We need to recreate the IMF. So we are going to take the lower subglandular tissue over here, and some scarpus fascia over here and fix it to the chest wall so that those three layers come together and recreate the IMF so that there is no bottoming out. So this. So now we have completed the breast augmentation for this patient. By paying attention to some key steps, the procedure is reproducible. You get the same results on both the sides. It's symmetrical. The markings were very important in the preoperative period so that they could guide us as to what to do intraoperatively. After that, complete hemostasis, meticulous dissection, and just following the steps which are already described give good consistent results. And more than that, preoperative discussion with the patient regarding the size of the implants is equally important. But the procedure itself is fairly simple if the proper steps are followed. Now, in this result, in the upper part, you can see that there is some swelling. This is all the bunched up muscle. So this will take a couple of months to settle down. But you can see once it settles down, it's going to give a nice natural slope in the upper part and a nice round contour in the lower part, which already the implant is giving. If this was in the subglandular plane, the borders of the implant would have been very visible. So it would have been very evident that she's got a breast augmentation done. But here the muscle is going to kind of slope till here, which is giving a nice cover and giving a nice natural result. So that is the difference between a subglandular and a dual plane technique.